Welcome to our conversation, AI Democratizing Access to Parent-Child Interaction Assessments. In this episode, Nicole Letourneau, Research Chair in Parent and Child Mental Health at the University of Calgary, Monica Oxford, Executive Director at the Barnard Centre for Infant and Early Childhood Mental Health in Seattle, and Linda Duffet-Leger, Associate Professor in the Faculty of Nursing at the University of Calgary, discuss their EQUIP project. An exciting project where this cross-organizational team is taking the well-known parent-child relationship assessment tool, Serve and Return, and developing an AI-enabled software program to rapidly code these interactions and make assessment available to all.
I'm Nicole Letourneau. I'm a professor and research chair in parent and child mental health at the University of Calgary. And I'm really excited to be here with Monica Oxford and Linda Duffet-Leger, who will introduce themselves in a second. We're going to have a great conversation about the really cool work we're doing as part of the EQUIP project. But meanwhile, I also wanted to give an important shout out to our team members, Shane Sinclair of University of Calgary, Cindy Lee Dennis of University of Toronto, Penny Trifonopoulos of University of Western Ontario, and Mohammed Moshapour of University of Calgary. Because we're all doing this work together, it's definitely a team effort. Wouldn't you say, ladies?
Yes. My name is Monica Oxford. I am faculty at the University of Washington School of Nursing, and I'm the Executive Director for the Barnard Center for Infant and Early Childhood Mental Health.
And I'm Linda Duffet-Leger, Associate Professor in the Faculty of Nursing at the University of Calgary. My program of research focuses on the user-engaged design of tailored digital health solutions. So I'm heavily involved with the software development team, leading the AI development for this project.
We've been working together for a long time, all three of us. It's great that we just continue to do really interesting work together. But I'm charged with providing a bit of the background here on this project that we're here to talk about. And it all really begins with understanding the importance of serve and return, or also known as parental sensitivity and responsiveness to infants and young children in relationships. And there's so much evidence, it's overwhelming to the point where everyone agrees that serve and return relationships are absolutely foundational to healthy brain development, brain architecture, mental health, and physical health over the lifespan. And so that's really what we all focus on to some degree. One of the ways that we have in our research examined serve and return relationships has been by what used to be known as the Nursing Child Assessment Teaching Scale. It's today known as the Parent-Child Interaction Teaching Scale, coming out of Monica's shop, and you'll hear lots about that in a little bit. But we've been using that tool for many, many years. It's been around since the mid-80s, I would say, right, Monica?
Yes.
And I became trained in the early 90s to administer it and train other people to administer it. And around the world, it's really thought of in many places by many people as the gold standard for how you assess serve and return relationship quality. Because serve and return relationships are so important, clinicians and researchers definitely use this tool in all kinds of places. One of the challenges, however, is that it takes a bit of time. You have to observe a parent and an infant or a young child playing together. It takes about 5 minutes. But then that nurse or social worker or healthcare provider who's trained will code what they just saw. It's videotaped, and then they code what they see. And we've been doing that for a long, long time. And then, making the best of it. But I think some of the time constraints of doing that coding maybe prevented it from being used as widely as it could be, even though it's quite widely used already. So an opportunity came along to us during COVID, one of those strange blessings that came from COVID. But we were doing a lot of research with families affected by things that undermine the quality of serve and return relationships they have with their children. So Linda and I and Monica were doing a study with mothers with depression and trying to help them improve the quality of serve and return relationships they had with their children in order to promote their children's development. Parental depression is a real factor that undermines the quality of serve and return relationships. So we were doing this program, this study, and enrolling families here in Calgary, and it was meant to be an in-person program where nurses, in this case, it's designed for nurses to deliver. Nurses were going to the moms' homes and helping them with their serve and return relationships with their babies, and we were collecting this data to assess the impact of the intervention on that outcome and the kids' development and so on. Of course, with COVID, we couldn't visit anymore. So we had to go online. And this is where Linda and her team really showed up in a huge, strong way, because they helped us turn the program into an online delivery modality. Linda and her team had some great ideas about how we could because we're already videotaping, we're already doing the intervention online, and we're doing it in the context of this app, this technology, Linda and her team had some great ideas around how we could automate the coding of the serve and return relationship quality using the parent-child interaction teaching scale. And that's what led us to apply to the AMS for funding. And we received $75,000 from AMS, which we're really grateful for, and totally launched this work. And Linda and Monica and I, led by Linda, we've really gone on to get a lot more funding to do some really interesting work. And we're really excited about the possibilities of automating the serve and return interaction coding, which will get this tool, we hope, into the hands of so many more clinicians to provide so many more parents in need with really timely feedback on the quality of their serve and return relationships with their children. I guess I'll stop there and just see Linda or Monica, if you have anything to add.
What I will just briefly talk about, Nicole, is what is the serve and return relationship and what does the PCI, or the parent-child interaction scale, capture? And it's based in decades of science that show, as humans, we send off signals and cues to people we're interacting with. And when those cues are responded to in a sensitive and responsive way, the quality of the communication and the quality of the relationship increase. Sometimes people have a difficult time detecting the cues of others socially, emotionally. Some caregivers, for example, those who might be struggling with mental health issues, might have more challenges in responding sensitively and detecting those cues. And so the serve and return that Nicole is talking about is the serve from an infant might be a smile. It might be the infant looking away because they're becoming overstimulated. And the caregiver's return is a detection of that cue and then adapting their behavior, changing their behavior in response to that serve. So if a child smiles, the caregiver smiles back. That's a completed circle of communication that increases the joy and quality and success of that interaction. Typically, what's really important in parent-child interactions is that the infant, when they serve cues that say, I'm getting overstimulated, I'm getting uncomfortable, I'm frightened, I need your help, those cues sometimes are harder to detect if they're subtle. So a look away, turning the head away, arching the back subtly, those cues are harder to detect. Crying, of course, is easier to see. But those cues, and that's what we're working with in identifying with the AI tool, is those cues tell the caregiver, I'm starting to get upset. And if we change what we're doing right now, we're going to have a more successful interaction. And that is how we support caregivers in really learning their unique child's communication strategy, because all babies communicate, but we all have our unique personalities, our unique temperaments, our unique characteristics that really the caregiver needs to learn, because the baby's brand new, and learning that can be really challenging, especially if there are other issues going on for the caregiver. So the PCI really is detecting the dance. Dr. Catherine Barnard, the namesake of our center, the Barnard Center for Infant and Early Childhood Mental Health, was really a pioneer in the 1970s and 80s in operationalizing what we call the dance, or the serve and return, that we work together to interact and to coordinate our interactions so that it brings joy and comfort and resolution of challenges. And so if we can support caregivers in understanding their infants' communications, they will have more successful interactions, and they will both feel more comfortable and experience more joy. And that's really what we do at our center, and what Nicole is doing with her research, is to support the resiliency and the strengths of the caregiver and the child, and the desire that all parents have to really get to know their baby and do the best possible job. I think that that's the core driver of our research, is to really elevate the parent-child relationship and the caregiver's capacity to meet that baby's needs.
Well said, Monica.
And I guess I'll add to that, as Nicole has said, we've worked together for many, many years, and serendipitously through the pandemic, we've had an opportunity to really look at how we can leverage technologies to really democratize access to these important tools and important evidence-based programs. Certainly, my role in this team is to bridge the divide between the health researchers with well-established programs like Nicole and Monica and those software development teams, so the technology experts, and really to create the most usable and the best system we can, the AI-enabled system that we're calling Equip. In my former life as a public health nurse and working in early childhood initiatives and listening to Monica and Nicole talk about the value of that serve and return relationship, I understand the value of how now we could use this technology to really democratize, access to these services and these tools. The AMS healthcare funding really allowed us and the software development team to explore existing technologies that we could really leverage in the development of this AI tool. So things like audio processing algorithms, speech language processing algorithms. It enabled us to find ways of really using those tools to identify those potent disengagement cues that Monica was talking about, where we focused on some of the behaviors, infant behaviors that were more easy to identify, and realizing that we could then build on the efficacy of those tools in developing something that was more refined for the needs of the very novel Equip tool.
EQUIP is an acronym. We love our acronyms. And EQUIP stands for Enabling Quality Interaction with Parents. But one of the things, too, that the AMS healthcare funding has enabled us to do is think about how to compassion to our use of technology. And we really think that that's what we're trying to do here. As Linda says, we're trying to democratize the access to some of these tools. So, that means that we talk to the people that are going to use the tools in the development of them. So have compassion towards the users of the tools, whether they're the healthcare providers or even the parents, ultimately, right? That will be accessing the tools in some fashion. And then the compassion also comes in, I think, when we think about ideally making the parent-child interaction teaching scale, the PSITS program, accessible to more people. That's our goal, is to make it something that a healthcare provider could have in their pocket and just take out and do a video and then get feedback on that video from that quick parent-child interaction and be able to give rapid feedback about serve and return. I mean, I think that's compassionate for the healthcare provider who's going to have a new tool. It's going to really help improve the quality of care that they're able to give. And that family is going to get really rapid feedback that'll actually improve the quality of parenting that child will receive. So, there's compassion for the family, for the child, for the healthcare provider. We're really trying to build that all the way through what we're doing. If we hadn't come across this opportunity with AMS Healthcare, I'm just really grateful because it has enabled us to take that idea of compassion and merge it with the importance of the AI technology. I hope Linda spends a little more time talking to us about, but merging those together in a way that, and demonstrating that it could work. We've demonstrated some success, and then turn that into additional funding. Because one thing we're certainly discovering is any kind of technology solution seems to cost more than you ever expect. So AMS Healthcare really got us started.
Nicole, you brought up compassion for the parents. I'd like to kind of offer a lens from the parent perspective. Nicole and I have been doing parent-child interaction intervention research for decades. And we have a very good lens towards working with families that are struggling. And our focus group work has really shown us, both focus groups with providers and focus groups with parents, that they very much appreciate the approach of observation. And that's essentially what we're doing. We're observing the interaction and looking for ways to support the quality of that interaction in a strengths-based manner. And what we hear from parents is, I didn't know my child was communicating in this way. I didn't know that this was going on. And I'm so grateful because now I understand my child better. I can see what he or she wants or needs. It sort of unlocks a visual that is obscured for many people and providers. When they learn when they are trained to do the parent-child interaction coding skills, it's a rigorous training. And we watch videotapes and we are training the providers to look for the serve and return, which is one of the unique aspects about the scale. A lot of scales look at just parent behavior or just child behavior, but we look at the contingency, or what Nicole is referencing, the serve and return, that these things happen simultaneously or almost simultaneously. When we train providers in that lens, their awareness of their interaction with parents and their interaction with their colleagues and their interaction with their supervisor, that this is sort of an untapped potential of understanding nonverbal language. And I think making the feedback more accessible to a wide variety of providers, but also more accessible to caregivers, because it will be easier and automated and lower error rate in coding. The AI will learn over time and correct itself, and through the technical aspects also correct it until it becomes reliable. The possibilities are really endless in how this could transform the way we provide support to families. And just what we've heard in our focus groups, our parents love it. They love learning about the language of their infant, not some random abstract infant, but their infant, that their infant might be more subtly disengaging than other children who have temperaments that are more easy to read. The potential, I think, is endless.
I agree. I'm super excited about the potential. And I mean, not just as a researcher, as a clinician, I think there's going to be huge applications. And I hope, I'm not putting you on the spot, Linda, but I would like to hear about your vision about how this app that we're going to create, we are creating, will work. Tell us maybe about what you think about short, medium, long-term kind of achievements that you hope for this. Because this is a program, not a project, right? We're in here to really develop this. It might take us a few years, but I'd love to hear what Linda has to say, hear about your vision.
To go back to what I was talking about before, as a public health nurse, 20 years ago, and I don't want to age all of us, but, we've been doing this for a while, and the opportunity for us to come together and bring our expertise together in the work that you do with children and families and the interactions between those, to bring the technology to it is just so exciting, because there is huge application to this. And had I been able to have this type of decision to support at my fingertips, in the palm of my hands, which is what we're talking about now, that we're developing a tool that will automatically give a clinician real-time decision support on the interactions between mother and babe, mother and child, parent-child, and then be able to guide them in how to really coach those behaviors and interactions so that they are conducive to positive relationships and developments. This is going to take a while. This is not something that happens overnight. We spent a lot of time kind of developing the data pipeline to get all the data that have coming from the two established programs of research from Nicole and Monica to really onboard and train the AI using the video data. And then it's going to be a process of really then it's that interchange between human and technology about yes or no. Is the AI really picking up accurately what the human behavior is? So in that, we've developed this human behavior software that allows our researchers then to code or timestamp that data that goes into the system and then feeds that back out to us so that we can then test and train that AI. But I see many, many applications for this with a real focus on leveling the playing field, providing access to these important insights, like Monica said, for not just clinicians, providers, families. Like we're really allowing this important evidence-based research to be provided to the masses. This is really what we live for as researchers, is be able to make our research as mainstream as possible, get it out to the people that really has a value to them and their families. And I think that is the real, what's really inspiring in this work, using the technology to really allow that to happen.
If you find these conversations interesting, Check out the AMS Healthcare website at amshealthcare.ca. There you will find information about our various funding programs, our 39 funded grantees and fellows in AI and compassion, and a wealth of resources on compassion and technology in healthcare. Now back to the conversation.
So Linda, do you envision it being like the nurse will have it on her phone, or the social worker or healthcare provider will have it on her phone, or she'll take it out and do a video? Is that kind of where you envision it?
Yeah.
Do you ever envision the parent just doing it on their own?
I don't want to cut out the middleman or anything like that. I mean, that is possible, right? But you talked about at the top of this, Nicole, about how we were engaged in developing the platform to deploy your program online. And so that was where this kind of came from, that idea that if we had that system or that tool embedded into this system, then it's already there for the nurse facilitators to use during the video feedback portion of the intervention. And so we also envisioned that we would have a mobile application of this, that a nurse in, say, public health nurse, other clinicians, social workers in the field, nurses in the NICUs, pediatricians could have this tool in the palm of their hand, that they could quickly do a video, record a video interaction, and get that real-time feedback about the quality of the interaction.
I'm going to actually add one of the other things I'm secretly thinking about, that it will improve the predictive ability of the parent-child interaction scales. So the parent-child interaction scales, which are disseminated out of parent-child relationship programs at the Barnard Center in Seattle, Washington, at the University of Washington, have a long, illustrious history of research. The scales have been used cross-culturally. They've been translated into multiple languages. They've been validated in multiple cultures. And they've been used in all types of populations. So children with medical risk, children with developmental delay, children with some sort of challenge that they're facing. And it's used to support the caregiver's ability to provide care to children who might have challenges in their communication strategies. I think the other research or scientific benefit that might come out of this is that the AI will pick up and over time become much more in depth in the interaction analysis. What we are providing right now is one lens, and I think the AI will provide a deeper dive into the data. And that actually will fine-tune our predictions. So using the parent-child interaction scales, we can predict cognitive development, we can predict child motor development. In some cases, we predict child social emotional development. So it's established as a tool that can predict developmental outcomes for children and for families. And it's an intervention tool so that we can evaluate our intervention. Did the intervention that we aimed to support parents in their caregiving, did it actually improve their caregiving? And that's the kind of research Nicole and I have done. We use the PCI scales to measure our parenting interventions to see if, in fact, we did improve the interaction quality. Well, with the additional depth of information that the AI will provide, our predictions of outcomes will be much, much more informed. I believe that we will increase the predictive capacity of this tool and understand the nuances of how development trajectories are either supported or challenged in a way that we really haven't had before because of the depth of what AI could provide us that the human eye really can't.
That's a really good point, Monica. I mean, and something else I've just been thinking about as we're talking here is, this wouldn't be possible without us doing it together, because you and I, Monica, have all this data to feed the AI. You couldn't be a junior researcher starting out trying to feed an AI data, right? And then we have Linda with her great ideas and innovativeness. You don't have the data, Linda, but you've got the methods that we don't have. So we totally, and your partnerships with Mohammed and his team, we really couldn't do it without each other. And we really couldn't do it without that long history that going back to the beginning with Catherine Barnard, with you, Monica, and all the data that you have. But we really couldn't do it without each other. And then the cool thing is that once our data have trained up the AI, we'll continue, like when it's out there being deployed, that becomes data that then continues to fine tune and improve the app. So it's pretty exciting. I mean, I'm looking forward to seeing where this all lands. I just don't think I can emphasize it enough. Like for me, this is my passion, helping families understand how to read and respond to their infant cues to promote their child's healthy development. Like that's my lifelong passion. Lots of things interfere with that. Parental mental illness, like depression, addictions, family violence, low income, like stresses and strains in families. This is where all my work is centered. And we haven't had, like, as wonderful as the parent-child interaction teaching scale is, and, it takes a lot of training, which we'll still probably need to do, right? There'll still be a training component, I think, Monica, for anyone who uses that. It's been a challenge to code. Like right now, I've got 300 videos in another project I need to code. The idea that we could just have the data, it's just kind of a bit mind-blowing. I don't know if we'll actually pray that we get there, but that's a bit mind-blowing. So from a research perspective, I think that'll mean that not only from a researcher perspective, that I'll be able to more rapidly use these tools in my research, but other people will too. Like the fact, serve and return is so foundational to healthy development. I mean, the Harvard Center for the Developing Child, it's one of their prime metaphors for everyone should understand how important early relationships are to development. They buffer the impacts of toxic stress on development. It's key, but because of the challenges for some people, not every agency can afford to train their staff to deliver PSITs or some lesser tool. I'm a bit biased. So not every agency can afford that, and certainly not every researcher can, but we all should be looking at this. In my opinion, this is so foundational that everyone should be examining it, thinking about it as part of everything they do. And this tool that we're working to develop will just enable us to get there that much quicker. Mm-hmm. I might be overstating a little bit, but I am pretty darn enthusiastic about the potential, because it'll actually enable us to put our money where our mouth is, sort of thing. We're always talking about the importance of serve and return. And yet it's pretty seldom that you actually see agencies or clinicians being able to assess that. But for example, in Canada, the province of Ontario has trained their public health nurses in these assessment tools. To my knowledge, no other province in Canada has. And I think it's a terrible shame. And it's just because Ontario has a bit more money, they put their priority there. But that means that 2/3 of the Canadian population, childbearing parents, aren't accessing that support, to my knowledge. So this kind of thing will change that equation and enable more people in more places to actually learn what it takes to have those optimal relationships and promote their children's development. Yeah. So,
the exciting thing is, like, we know this is a unique tool. This, our exploratory work really identified this as, I guess, ahead of the wave in many respects, and has tremendous potential. And to build on what Monica was saying as well about the predictive ability, there's certainly lots of evidence to suggest that the AI, the technology, can actually eliminate some of the human biases that become part of that coding process. And of course, that really is determined by the amount and quality of the data that we put into the AI, which is, again, back to Nicole's point, a junior researcher could not do something like this. It requires thousands of video data to go into the AI to actually train it and make it a effective and unbiased AI tool.
I wanted to add my thanks to Monica for being so willing to partner with us. Monica runs a center that trains people all around the world in a not-for-profit model. And I just want to say how grateful I am, Monica, for you to work with us on this, because you don't need to. I mean, I think you see the potential, and we're all working for sort of similar aims, but I just want to say thanks.
Thanks, Nicole. I appreciate it too. You have been such a great partner in using the PCI scales and really helping us think through strategies of the intervention you're doing, the brief intervention that you are facilitating through the VidKids program, which is so exciting that in 3 sessions you can get the kind of effects that you're getting by focusing on the parent-child nonverbal communication. And so it's been such a great partnership. And then to join Linda and her team and Mohammed, it is a unique partnership that we have very different expertise in the same room trying to solve this one issue. We all speak sort of different languages. Actually, Nicole and I speak the same language, but it's been a process of learning and really reflecting on how to work together as a team. And so I appreciate yourself and Linda and Muhammad and all of the effort that has gone into making this a collaborative project and the funding from AMS Healthcare to get us started, to really provide us the foundational funding to think big and to think in an innovative way about how to change practice for nurses and social workers.
Monica, before Linda goes, I just want to think, because I want you to wrap up for us, Linda, because we couldn't do any of this without you and your team. But, you spoke about language, Monica, and one of the things was the word coding.
Yes.
We talked about coding.
Yeah,
we talked, maybe I'm still your thunder, sorry, but we talked about coding in the parent-child interaction teaching scale world. Is, you code, is the parent smiling and then making eye contact, is the baby reaching, is the baby, smiling. We code those behaviors. Of course, coding is a totally different thing in Linda's world. So we have to say, okay, we're not going to call it coding anymore in this context because it confuses everyone. So anyway,
we've had many of those language conversations, which has been fascinating.
We have, and we often create a glossary as part of our communication strategy because of these things. Coding being one of the primary words that keeps coming up, because coding in your world is very different from coding in a software developer's world. And I guess it really highlights the importance of the communication piece. So the partnerships are really important. The interdisciplinary team is really important. But how we communicate together to come up with the best system, that is paramount. I want to thank everyone here, primarily the AMS Healthcare, for helping seed this, but also the amount of collaboration and collegiality between the team to really work with the software developers and to the software developers who have been so responsive to the team, because it is that reciprocity between the two that helps us develop the technology. At the core of this is communication. So I think we're all learning how to work together, and that has been really, really valuable with this end goal that Nicole and Monica have talked about really helping families in our communities and be the best that they can be as a family unit. So I think that's what's really inspiring to me.
Thanks for joining us for this inspiring conversation on the importance of assessing parent-child interactions and the exciting work of this team using technology to bring the assessment to all parents and children. And a big thanks to Nicole, Monica, and Linda for telling us all about it. And please connect with us again for the next AMS Healthcare conversation on good tech, compassionate healthcare.
Blah, 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 blah.